from organizing committee of Covai Heart Rhythm Summit, we welcome you all for this wonderful meeting. Thank you for making it on a Sunday morning. Let's start with the meeting. Let me first invite moderators for this first session, Dr. Nambirajan sir, Dr. Susil Kumar sir, Dr. Sujay Nikhil, Dr. Ramasamy sir and Dr. Ateep sir to take over the dais. Thank you, sir. Let me also invite my friend and colleague, Dr. Ranganathan, to start the session with this topic on hypertension. Thank you.
A very good morning to one and all. At the outset, I'd like to thank Lawrence sir for the opportunity. I'll be talking on a simplified approach to hypertension. This is the outline of my talk. For the next 15 to 20 minutes or so, I'll walk you all through the following topics. We'll see how the hypertension guidelines evolved, what is the importance of proper blood pressure monitoring, how do you classify hypertension, what are the thresholds for initiation of therapy, and what is the choice of therapy. And then I'll close with few major takeaways. This picture was taken in the year 1945. It is a very important picture in the context of this presentation. You can see three very important personalities here in this picture. On the left is Winston Churchill. In the middle is Franklin Roosevelt, who was the US president then. And then on the right is Joseph Stalin. All three of them had one thing in common. All of them died because of hypertension-related complications. And Franklin Roosevelt died because of hypertensive intracranial hemorrhage. And his blood pressure was found to be 300/180 just before he passed away. Until this event, hypertension was considered to be a compensatory mechanism and not much interest was shown in the evaluation and management of hypertension. It is only after this incident that US took an initiative and then started this Framingham heart study. This is a study, it's a landmark trial wherein they assessed if hypertension and dyslipidemia are risk factors for myocardial infarction. The results of the trial came and the rest is history, as you all know. Now fast forward to 2023 and we have the latest European Society of Hypertension guidelines. I put this classification here from the European Society because it is very similar to the Indian hypertension guidelines. This classification of blood pressure is applicable for individuals above 16 years of age. And this classification is based on recording of blood pressure in the clinic with the patient in sitting position and using an automated oscillometric BP apparatus. They have categorized the blood pressure into 7 categories. A person is said to have optimal blood pressure when the systolic is less than 120 millimeters of mercury and diastolic less than 80 millimeters of mercury. And then further categorization of blood pressure is based on the highest BP reading, be it systolic or diastolic. By that I mean, for example, a patient has a systolic blood pressure of 140 and diastolic blood pressure of 80. Although diastolic is in the normal range, we have higher reading as systolic, which is 140, and so this patient has to be categorized as having grade 1 hypertension. Likewise, suppose a patient has systolic of 130 and diastolic of 100, then he comes under grade 2 hypertension. Even though systolic is in the high normal range, we have diastolic blood pressure as 100, which comes under grade 2. So categorization is based on the highest level of blood pressure. That's why I put and/R for systolic and diastolic blood pressures. And a patient is said to have isolated systolic hypertension when the systolic blood pressure is more than or equal to 140 and diastolic less than 90 millimeters of mercury. So hypertensive range is systolic more than or equal to 140 and or diastolic more than or equal to 90 millimeters of mercury. Before I go further into the presentation, it is very important to accurately determine the blood pressure because this is the cornerstone for the diagnosis and management of hypertension. So I thought it's worthwhile spending a couple of minutes on how to accurately determine blood pressure. First, going to the devices, there are several sphygmomanometers that are currently available in the market. We have manual devices and then we have the automated devices. In the manual devices, we have mercury sphygmomanometers, which are now phased out in many countries and is in the process of being phased out in India as well because of the hazards which mercury causes to the environment. And then we have the aneroid sphygmomanometers, and then we have the hybrid LCD sphygmomanometers. This one is very similar to the mercury sphygmomanometer. But one difference is that the Mercury column is replaced by a digital screen which gives you the systolic and diastolic readings. And then we have the automated devices. There are two types. One is automated oscillometric device and the other one is automated auscultatory device. The difference is in the mechanism by which they record blood pressure. In automated oscillometric device, we have a small sensor in the cuff which records the pressure and the volumetric changes within the brachial artery, and then it generates an oscillometric waveform, and from which we estimate the systolic and diastolic blood pressures. In the automated auscultatory device, we have a small microphone in the cuff which records the Korotkoff sounds, and then based on this, we estimate the systolic and diastolic blood pressure. Both look the same, it's just the mechanism by which they work is different. So what is the recommendation for BP measurement? What device does the guidelines recommend? Guideline recommends an automated electronic upper arm cuff device for blood pressure measurement, both in the office and out of office. And aneroid devices and hybrid devices can be used if automated devices are not available. And make sure when you buy an automated device, you buy a validated one. And we have to keep checking the integrity of the device once in a month or so. Look at the tubing, look at the cuff, everything, so that we record the blood pressure properly. This is a very well-known slide to many of us. This is how we record blood pressure. When the patient comes to the clinic, make sure he is in a quiet environment. He shouldn't have smoked, he shouldn't have had coffee or food in the prior 30 minutes before we check blood pressure. With regards to the sitting position, he has to be seated on a chair with a backrest. The feet has to be on the floor. The legs shouldn't be crossed. And when you tie the cuff, make sure you tie it on the bare arm. And then if the blood pressure is being recorded in the home, we have to take 2 recordings 1 minute apart and then use the average reading for the measurement. If it is in the clinic, take 3 recordings each 1 minute apart, ignore the first one and then take average of the last 2. So what blood pressure do we use to diagnose hypertension and to initiate therapy? According to the guidelines, it is the office blood pressure that is recommended for diagnosis of hypertension because all the studies, the hypertension related risk assessment, benefits of therapy, treatment thresholds and goals are all based on office BP recordings. But that doesn't mean out of office BP measurements like the one we use with home BP monitoring and ambulatory BP monitoring are not important. They are very, very important because they give multitude of information regarding blood pressure. You get nighttime readings, you can assess white coat hypertension, masked hypertension, everything only through out of office blood pressure measurements. So whenever feasible, you can use HBPM and ABPM for your patients while managing hypertension. This is ambulatory report of an ambulatory blood pressure monitor. What we do in this ambulatory BP monitoring is, it's a device that is similar to the automated device. There is a cuff that is tied to the arm and then there is a smaller device that is tied to the waist. Patient comes to the clinic, we put in the ambulatory BP monitor. The patient is made to be in the hospital for at least 20 to 30 minutes and we program the device in such a way, we record blood pressure every 20 minutes throughout the day and night. That is the recent recommendation. And then the patient comes back the next day to the clinic to hand over the device. So when we generate a report, it comes this way. You can see here, the systolic blood pressure is slightly on the higher side during the awake period. Diastolic blood pressure is okay. And then the blood pressure begins to dip during the sleeping period. That is, the blood pressure begins to dip. This dip has to be between 10% and 20% of the average daytime readings. If it is between 10 and 20%, we call it a normal dipping pattern. And this, once the patient wakes up, the BP again starts rising. This nighttime dipping is very, very important. People who dip extremely or who do not dip have adverse cardiac prognosis. This is another reading. You can look at this one. The patient has slightly elevated systolic and slightly lower diastolic, but look at this nighttime sleeping period. Instead of dipping, in fact, the blood pressure rises here. So we coin this patient as a nocturnal riser, and this also carries adverse prognosis. And this clearly shows how we diagnose white coat hypertension. The patient has come to the clinic, we put in the device, and then the first 20-30 minutes he is in the hospital. You can see here the blood pressure is high initially in the hospital, and then once he gets back home, blood pressure starts coming down. It dips normally, and then again the next day morning he goes to a meeting where he attends a meeting, and then blood pressure starts shooting up. So this is a classical example of white coat hypertension. All these we'll be able to make out only when we use out of office BP monitoring. So we get additional information like white coat hypertension, we can diagnose masked hypertension, we can assess the dipping status if the patient is a non-dipper, if the patient is a riser or extreme dipper. Now that we know what device we use, how do we, what is the threshold for diagnosing hypertension and all that. So what is the significance of measuring blood pressure in both arms? It is very, very significant because normally there is an inter-arm blood pressure difference. When this difference is less than 15 millimeters of mercury, it doesn't matter. But when the blood pressure difference between arms is more than 15 millimeters of mercury, then you need to assess for atherosclerotic vascular disease. And whenever there is a blood pressure difference, make sure you record the blood pressure in the arm with higher reading. In subsequent visits, you need to make sure you record blood pressure only in the arm with higher blood pressure reading. Even if you are not able to measure blood pressure in both arms during every visit, at least during the first visit, it is very, very important that we measure blood pressure in both arms. And this is a data, Indian data done by Gurpreet S. Wander et al. It's a large study wherein more than 1 lakh patients were studied and all of them had an automated BP monitoring. What they found out was by measuring blood pressure in both arms, they were able to diagnose hypertension in additional 6% of the participants, which means blood pressure was normal, blood pressure was in the normal range in one arm and it was in the hypertensive range in the other arm. So if you had measured blood pressure only in one arm, you might have missed this 6% of patients with hypertension. So it is very important that we measure BP in both arms. So how do we diagnose hypertension? Patient comes to the clinic, you check blood pressure, it is in the grade 1 range or grade 2 range. You immediately cannot deem the patient to have hypertension. If it is in the grade 1 or grade 2 hypertension range, let the patient go, get back in 2 to 4 weeks time, recheck blood pressure. If the blood pressure is still in the grade 1 or grade 2 hypertension range, then you diagnose hypertension. Scenarios where you diagnose hypertension even during the first visit is even if the blood pressure is in the grade 1 or grade 2 range, but if it is associated with hypertension mediated organ damage like LVH in the ECG, albuminuria in urine routine, or retinopathy in fundus examination, then you can diagnose this patient to have hypertension. Or if the patient has grade 3 hypertension, when the blood pressures are more than 180 over 100, then you can diagnose hypertension even during the first visit. How do you initiate therapy? What are the thresholds for initiation of drug therapy? You categorize patients into 2 groups. One group is 18 to 79 years and the second group is the older population, more than 80 years. So for patients between 18 and 79 years, initiate therapy when systolic is more than 140 and or diastolic more than 90. You can initiate therapy earlier if the patient has associated high cardiovascular risk in the form of established cardiovascular disease. You can see this here, 18 to 79 years when the patient has established cardiovascular disease, initiate therapy even when the blood pressure is more than or equal to 130 over 80. And for patients more than 80 years, initiate therapy when systolic blood pressure is more than 160. All these are class 1 recommendations. That's why I've shaded it in green. And then now you have the class 2 recommendation. Any patient more than or equal to 80 years, you can initiate therapy when systolic blood pressure is between 140 and 159, but it's a class 2 recommendation. And for frail patients, you need to individualize because frail patients may not tolerate better. So depending upon their tolerance, you initiate therapy and target levels are also based on the individual patients. So we initiate therapy. What is our goal? What is the target blood pressure? Systolic blood pressure, we want it to be between 140 and 120. We do not want to reduce systolic blood pressure below 120. Likewise, diastolic BP, the ideal target is between 80 and 70. We do not want to reduce diastolic BP below 70. And for elderly individuals above 80 years of age, our ideal target would be to attain a systolic blood pressure below 150 millimeters of mercury. And what happens, why do we not want to reduce blood pressure below 120/70? You can see this data here. When the systolic blood pressure is reduced to below 120 here, the hazard ratio starts increasing. So the sweet spot is between 120 and 140 where the hazard ratio is minimal. Likewise, diastolic blood pressure, do not reduce below 70. When you reduce it below 70, again the hazard ratio starts increasing. So now we have looked at the threshold for initiation of therapy and target levels. So what antihypertensive medication do we start with? According to the latest recommendations, BP lowering is prioritized over selection of specific antihypertensive drug classes. That is, reduction is more important over selection. So whatever drug you may use, our goal is to reduce the blood pressure. Whatever drug it may be, reduction of blood pressure results in better cardiovascular outcomes. There are 5 drugs which are considered as first-line drugs for treating hypertension. They are ACE inhibitors, angiotensin receptor blockers, beta blockers, calcium channel blockers, and diuretics. And when blood pressure is not controlled with these medications, either as monotherapy or with combination, then we use second-line agents like alpha blockers, example prazosin, centrally acting agents like clonidine or moxonidine, and mineralocorticoid receptor antagonists like spironolactone. These drugs come under second-line category because we don't have enough outcome-based trials on these drugs, and these drugs are associated with slightly higher risk of adverse events and side effects. So this is the first-line therapy. We have ACE inhibitors. I'll just give a couple of points for each drug. Why do we choose this drug? ACE inhibitors, ARBs, we have large outcome data. They are very safe, well tolerated. We can use ACE inhibitors or ARBs in patients with heart failure, in patients with CAD, in patients with CKD, in patients with LVH. But one contraindication, very important contraindication is please do not use these drugs in patients who are planning for pregnancy or who are pregnant. Also, it's contraindicated in patients with bilateral renal artery stenosis. CCBs, talking about the dihydropyridine calcium channel blockers like amlodipine, benidipine, and azilnidipine, extremely safe, well tolerated, can use in any group of patients. They have no specific contraindications. And then we have diuretics. We have thiazide type diuretics and thiazide like diuretics. Thiazide type is hydrochlorothiazide, and thiazide like diuretics are indapamide and chlorthalidone. Generally, thiazide-like diuretics like indapamide and chlorthalidone are more potent, they are more longer acting, so it's better that we use thiazide-like diuretics. One caution is when you start a patient on diuretics, see if the patient has any dysalkylatemia, avoid when the patient has hyponatremia or hypokalemia. Likewise, when the patient has gout, be extremely cautious. And then beta blockers. The latest guidelines have upgraded beta blockers in the management of hypertension. Previously, beta blockers were not included in first-line therapy for hypertension because they were not neutral on lipids. They increased the incidence of new onset diabetes and so on. But now with newer beta blockers, especially vasodilating beta blockers like carvedilol and nebivolol, they do not increase the incidence of diabetes. They are neutral on lipids. They have 24-hour action. They are very well tolerated. They have very minimal airway resistance. So beta blockers have now found their place in the first-line drugs for management of hypertension. And while what the guidelines recommend is any patient on hypertension start with a combination therapy. The initial combination is, you can see the dark blue lines here. It is going to be either ACE or ARB with a calcium channel blocker or ACE or ARB with a diuretic. This is the first-line combination. If this combination does not work properly, patient still continues to have elevated blood pressure, then you can use this triple drug combination, ACE, CCB, and then diuretic. All these 3 blue lines. Now the latest addition is this combination of beta blocker with ACE inhibitors. I'll just finish in 2 minutes. Beta blockers with ACE-ARB combination can be used in multitude of conditions. It can be used in patients with arrhythmia and hypertension, pregnancy and hypertension. ARB cannot be used. I mean beta blockers are used in patients with pregnancy and hypertension, arrhythmia and hypertension, patients with tremors and hypertension, migraine hypertension. And one important point to consider is any patient with hypertension and resting heart rate more than 80, then beta blockers are the first choice of therapy. So this is how you approach a patient with hypertension. Any patient you diagnose hypertension, make sure you suggest them all the lifestyle modifications like weight reduction, to quit tobacco, to increase the dietary potassium and reduce dietary sodium. Start with combination therapy. As we discussed, it's RAS plus CCB or diuretic. If the blood pressure is not controlled, RAS inhibition with CCB and a diuretic. 90% of the times the blood pressure is controlled here. If still it's not controlled, then you need to evaluate for resistant hypertension. And as we discussed, beta blockers can be used at any step of combination therapy. The rationale for why ARB plus beta blocker combination is coming up. This is a very interesting article published by Stewart Julius et al. You can see here on the y-axis is the event rate. The first one here, the heart rate is less, blood pressure is controlled, the patients do well, the event rate is less. But if the blood pressure is controlled, but still the heart rate is more than 80, the hazard ratio or the event rate is very high. So it is not enough when you just control the blood pressure. You also have to make it sure you reduce the heart rate as well. The magic number is 80. Any patient with resting heart rate more than 80, make sure apart from controlling the blood pressure, you also control the heart rate. Now that we have given all three medications, still the BP is not controlled. What do? We have to first rule out white coat hypertension or white coat effect. So what we do is we put the patient on an ABPM to rule out white coat effect. If the blood pressure is still more than 140/90 even at home, then we need to verify adherence. This is very important because in our day-to-day practice, we have many patients who are not adherent to the medications. And then we also need to rule out OSA. Still the blood pressure is high, you check for drugs that interfere with antihypertensive medications efficacy, like NSAIDs. Even paracetamol is found to increase blood pressure. We have nasal decongestants, antidepressants, sodium-containing antacids, glucocorticoids, and so many other drugs. The list is incomplete. Even immunosuppressive agents, azole antifungals, all can increase blood pressure. So what happens? Your patient is adherent, ambulatory BP monitoring shows no white coat effect. Still the patient's blood pressure is high. What do? You can add spironolactone. If not, you can add an alpha blocker like prazosin or centrally acting agent like moxinidine or clonidine. You can also consider renal denervation if all these fails. And renal denervation is a class 2 indication for resistant hypertension treatment. With this, I'll close and thank you one and all for the patient listening.